Hello, my name is Chanel Santana, and I'll be discussing poverty and adverse childhood experiences in low income families and early childhood development. I will define this population, discuss their risk factors, and share evidence based nursing interventions that can make an impact in their lives. This population includes children from birth to age 5 and their caregivers living in low income households earning less than 30,000 annually. In Midwestern metropolitan areas, a single mother demographic is approximately 36% white, 41% Black or African American, and 7% Hispanic or Latino, with studies showing up to 71.9% of their children in non parental child care. Caregivers often have limited formal education and live in both urban and rural areas. Those in rural settings face even greater challenges, including higher rates of child maltreatment and less access to support services. Understanding these characteristics helps us see the full picture of who these families are. This population faces many risks. Approximately 20% of mothers in low income cohorts score above the risk threshold for depression. This leads to dysregulated parent child interactions, diminishing a parent's capacity to engage in emotionally supportive ways. Second, families face economic hardships like eviction threats and utility shutoffs. They lack institutional resources like bank accounts or savings, creating chronic stress. Third, children are at high risk for ACEs, witnessing violence, parental substance abuse, neglectful parenting, and living with a single parent. Fourth, developmental risks reflect data showing that by age 2, children in these low settings score below the norm in receptive language. They also face higher risk of aggressive behaviors and lower school readiness in literacy and in math. Even when families want health care, they face significant barriers. Without reliable vehicles, especially in rural areas with limited public transit, this can mean fewer providers and longer distances. There are financial and language barriers. The healthcare system itself is difficult to navigate. Some families distrust the health system due to historical discrimination or fear child welfare involvement. Depression itself reduces motivation to seek care. These barriers explain why the families most in need are often least able to access services. Key nursing interventions include ACEs screening and language assessments for early risk identification, mental health support and trauma informed care, home visiting and telehealth to reach rural families, and culturally sensitive practices that respect diverse backgrounds and empower parents. These strategies reduce disparities and improve access to care. Research supports these interventions. The family stress model shows poverty harms children indirectly through parental distress and dysfunctional interactions, which impair language. ACEs follow a dose response pattern. More adversity means greater risk. Children with 3 or more ACEs by age 5 face attention problems, low academics, and placement in non parental care. Finally, parental involvement matters. When parents engage in school activities, children score higher in literacy and lower in aggression. Positive parent teacher relationships also boost math scores. When we bring this to a local context, rural children have higher maltreatment rates and more non-parental care placements. Limited services, transportation barriers, and lack of universal ACEs screening and trauma informed training are major gaps. Local nurses can fill these gaps by implementing ACEs screening in pediatric settings, training staff in trauma informed care, and developing mobile health clinics and telehealth for rural families. By investing in our youngest children and their families, we can interrupt cycles of poverty, promote lifelong health, and build a more just society. As nurses, we are uniquely positioned to lead this change. Thank you. Any questions?